Bismillahirrahmanirrahim. Quote of the day. If Allah helps you, no one can defeat you. Al Quran. Assalamu alaikum everyone. I am Dr. Marina Akhtar, PGR Community Medicine. Today my topic of presentation is polio. I am presenting this topic under the kind supervision of my professor Dr. Saira Afzal. Learning outlines. Introduction of the topic epidemiology, its clinical features, its diagnosis, treatment and prevention, its complications, polio vaccine and its types, indication, reaction and contraindication, recent updates and MCQs. Learning outcomes. At the end of this presentation, the participants will be able to describe the epidemiological factors, prevention, control of polio, and the importance of polio vaccine in disease elimination, global and the national strategies for polio eradication. What is polio? Poliomyelitis or polio is a highly infectious viral disease that largely affects children under 5 years of age and caused by poliovirus. Poliovirus is transmitted by the person to person, spread mainly through the fecal-oral route or less frequently by a common vehicle, for example, contagious water or food or contagious surfaces, and multiplies in the intestine from where it can invade the nervous system and cause paralysis. Its stereotypes. Spherical virion with a single stranded RNA. It has three serotypes, 1, 2, and 3. And type 1 is also called Bernheim and monostrains. And type 2 is also called Lansing and MEF1 and Leon and Socket. It's type 3. Its resistance, poliovirus is resistance to ether, chloroform, bile, intestinal, proteolytic enzymes, and detergents. It is stable at pH of 3. It can survive at minus 20 degrees centigrade for years and 4 degrees centigrade for months, and at room temperature for 1 day to several weeks. It is inactivated by heat 55 degrees centigrade for 30 minutes and formaldehyde and ultraviolet light and chlorination. Pathophysiology of the poliomyelitis. Poliovirus is shed in feces and saliva transmitted by the fecal-oral or respiratory route. It replicates in the oropharyngeal and the lower gastrointestinal tract mucosa and enter the cervical and mesenteric lymph nodes. A primary minor viremia follows with the spread of the virus to the reticuloendothelial system. Infection may be contained at this point, or virus may further multiply and cause several days of secondary viremia and culminating in the development of the symptoms and antibodies. In the paralytic infections, poliovirus enter the central nervous system either via secondary viremia or retrograde migration through peripheral nerves. Life cycle of the polio. It enters the body. Poliovirus enters through the mouth, typically in the contaminated food or water. Settling in the virus first infect and replicate in the cells of the intestine. From there, it can enter the bloodstream, attacking the body. In one out of the every 200 cases, the virus attack the central nervous system, destroying cells in the spinal cord. And fourth is paralyzing. The destruction of the nerve cells result in the paralysis, usually in the legs. Fifth is leaving the body. The virus is excreted in the feces that can contaminate food, water, and especially in the area of poor sanitation. Effect on CNS, nervous system or CNS. In nervous system, it multiplies in the neurons and destroys them. Earliest changes were degeneration of the nasal bodies, followed by nuclear changes and finally neuronal death. In spinal cord, lesions are mostly in the anterior horns, causing flaccid paralysis, and posterior horns and intermediate columns may be involved. Epidemiology. In the polio, agent is Picorna viridae or polio virus, and the host is human being. And environment is poor sanitation, vaccine inaccessibility, and the places with high level of diarrhea. And epidemiology include reservoir includes humans and transmission through fecal oral or possibly rarely oral or through droplets or contaminated food or water and close and sometimes close contact with infected persons through infected hands, infected surfaces. And communicability is 7 to 10 days before or after onset, and virus present in the stools 3 to 6 weeks. Types. Three types of polio: asymptomatic polio, non-paralytic, and third is paralytic, which is further divided into the spinal, bulbar, and bulbospinal polio. Asymptomatic polio accounts for approximately 95% of the cases. Virus stays in the intestinal tract and does not attack the nerves. Virus is shed in the stool, so infected individual is still able to infect others. So their infected stools may be spread, may become the cause for spread of the polio. Non-paralytic polio. Abortive poliomyelitis does not lead to paralysis. Mild symptoms seen such as sore throat, fever, diarrhea, constipation. These are minor illnesses and mostly recover in less than 1 week. Non-paralytic aseptic meningitis. This is the major illness of non-paralytic poliomyelitis. It occurs in 1 to 2% of the polio infections. Symptoms are stiffness in the neck, back, or legs. Increased or abdominal sensation can occur. Sorry, increase or abnormal sensation can occur, and complete recovery after 2 to 10 days of the symptoms. Paralytic polio. Fewer than 1% of those infected develop this type acute flaccid paralysis scene. Initially focal but spread over 3 to 4 days where symptoms are headache, neck and back stiffness, unusual sensations, increased sensitivity to touch, tripod sign, and descending paralysis asymmetrical patchy paralysis, and deep tendon reflex lost before onset. Spinal polio, most common form of paralytic poliomyelitis, 79%. It is 79% attack motor neurons and causes paralysis of the muscles of respiration and muscles of the extremities. Mostly involves children less than 5 years, most likely to become paralyzed in one leg, and adult most commonly paralyzed in both arms and legs. Those infected still retain sensation in the extremities. Bulbar polio accounts for 2% of the paralytic polio. It virus attacks motor neurons in the brainstem. It affects the cranial nerve function and primarily inhibits ability to breathe, speak, and swallow effectively. Bulbospinal polio accounts for 19% of the paralytic cases, affect the extremities and the cranial nerves, lead to severe respiratory involvement. Paralytic polio risk factors. Risk factors include compromised immune system, pregnancy, mouth or throat surgery, and injury or strenuous physical exercise after exposure to virus. Treatment. There is no cure for polio. It can only be prevented by immunization. Treatment for polio focus on limiting and alleviating symptoms. Heat and physical therapy can be used to stimulate the muscles, and antispasmodic drugs are used to relax the affected muscles. This can improve mobility but does not reverse permanent polio paralysis. Post polio syndrome. It can occur in the 25% of the individual decades after recovering from the acute infection. Its features include muscle weakness, extreme fatigue, or paralysis due to failure of the oversized motor units created during recovery from the paralytic disease. Symptoms and the signs of the post polio syndrome includes fatigue, muscle atrophy, muscle and joint pain, and breathing difficulties. Stats. Uh, while wild polio virus cases have decreased by over 99% since 1988 from an estimated 350,000 cases in more than 125 endemic countries to 6 reported cases in 2021. Of the three strains of the wild polio virus type 1, type 2, type 3, wild polio virus type 2 was eradicated in 1999 and wild polio virus type 3 was eradicated in 2020. As at 2022, endemic wild polio virus type 1 remains in two countries in Pakistan and Afghanistan. This table showing the wild polio virus cases across the Pakistan's different provinces in different years. To 2024, there are still total polio cases 59. Global Prevention Program. In 1988, the World Health Assembly passed a resolution to eradicate polio to achieve its permanent reduction to zero, with no risk of reintroduction. And in the same year, the Global Polio Eradication Initiative was launched. World Polio Day is October 24th, and the prevention of program of the Pakistan. The National Emergency Action Plan NEAP is the annual document that outlines the eradication strategy of the program and its strategic priorities. The program is currently implementing the National Emergency Action Plan NEAF for the polio eradication 2020. As per the NEAP 2020, the program is committed to stopping the all wild poliovirus type 1 and vaccine-derived poliovirus type 2, VDPV2, and transmitted in the Pakistan. To achieve this goal, the program is focused on ensuring the following objectives: stopping poliovirus transmission in all remaining wild poliovirus type 1 reservoirs through focused, intensified national efforts, rapidly detecting, containing, and eliminating all polioviruses from any newly infected areas. The creation of a new area of the work which concentrates on building a synergy with the EPI expanding program on immunization. Through this area of the work, Pakistan hopes to improve essential immunization coverage of the children while addressing broader health needs through the provision of the expanded packages comprised of health, nutrition, and wash services. High risk districts. The program uses four district risk tie to classify areas according to the risk they present and to devise risk appropriate eradication strategies and activities. Core reservoir district or type 1 district, high risk district or type 2 district, and vulnerable district or type 3 district, and low risk district, type 4 district. As showing in this pictures, different regions with type 1, type 2, type 3, and type 4. Super high risk districts. Super high risk union councils comprised of the dense underserved population group with poor level of immunization against polio and will receive laser focus in terms of the eradication interventions and strategies by the program. The provisional breakdown of the super high risk super high risk union councils as shown in the table below. These are the provinces and districts are showing, and union councils, number of union councils. These are super higher risk union consuls. Polio vaccination. Polio virus vaccine in 1955 inactivated vaccine was discovered in 1961 type 1 and type 2 monovalent OPV, and 1962 type 3 monovalent OPV in 1963. In 1963 trivalent OPV, and in 1987 enhanced potency IPV were introduced in the Pakistan. Inactivated polio vaccine developed in 1952 by John Salk contain three serotype of vaccine virus, 40 units of 1 and 8 units of 2 and 32 units of 3. Grown on monkey kidney cells inactivated with formaldehyde and contain trace 2 pheno, uh, phenoxyethanol, neomycin, and streptomycin and polymyxin B. Safe in immunocompromised and in the pregnancy, IPV. Inactivated polio vaccine or IPV heat stable at the room temperature but should be refrigerated to preserve potency. Highly effective in producing immunity to polio virus. Greater than 90% percent people are immune after 2 doses and 99% immune after 3 doses. Humoral immunity and to some extent pharyngeal immunity is also achieved. Duration of immunity is not known with certainty. OPV, oral polio vaccine, discovered by Albert Sabin, contain three serotypes of vaccine virus, 3 lakh T-seed 50 of type 1 and 1 lakh T-seed 50 of type 2 and 3 lakh T-seed 50 of type 3. It grown on the monkey kidney vero cells and contain neomycin and streptomycin. Oral polio vaccine produce both humoral and local immunity. It contribute to the herd immunity. 50% immune, 50% people immune after 1 dose and 95% immune after 3 doses. Immunity probably lifelong and it is heat liable. Minus 20 degrees centigrade can be stabilized by adding magnesium chloride. Should not be frozen and thawed rapidly. Polio vaccine adverse reaction include rare local reaction of especially of IPV, and no serious reaction to IPV have been documented, and paralytic poliomyelitis that is observed in OPV. Polio vaccine contraindications, severe allergic reaction to vaccine component or following a prior dose of the vaccine, or moderate to severe acute illness. Vaccine associated paralytic polio. Mutation of the vaccine inside the body may cause loss of the attenuation itself brought on by reversion leads to paralytic polio. Increased risk in person greater than 18 years and those with the immunodeficiency B cells. Vaccine-derived paralytic polio virus. These viruses, like those causing vaccine-associated paralytic polio, are neurovirulent but additionally are transmissible and capable of causing outbreak. They have been classified into three groups: circulating uh, VDPV, vaccine-derived paralytic polio virus, and VDVP in the immunodeficient, and VDVP of ambiguous origin, AVDVP. Risk factors for outbreak due to circulating VDVP include dropping immunization coverage, high population densities, tropical conditions, and previous eradication of the wild virus. Circulating vaccine-derived poliovirus type 2 polio cases across the Pakistan's provinces. These are data of different uh, different provinces of Pakistan and with reference to different years. Administration of OPV. 2 drops of OPV are used. Nose should not be pinched. Instead, apply pressure to both sides of the mouth. Breastfeeding is not contraindicated. Hot liquid to be avoided for half hour after OPV. Cold chain. The system of transporting, storing, and distributing vaccine is a potent state at the recommended temperature till it is administered to an individual. If cold chain is not maintained from the manufacturer to the place of vaccination, the vaccine efficacy greatly suffer. The most vaccine lose their potency by heat and sunlight and hence need protection from both. Vaccine while monitoring. The vaccine while monitor is a small thermochromic sticker on the vaccine vial and changes color as the vaccine is exposed to heat. The color of the sticker tells whether the vaccine must be discarded due to excessive heat exposure. It reduces uncertainty and waste. This picture showing the different colors on the vaccine vials. Now coming to the recent updates. Our first article is poliomyelitis in Pakistan and challenges to polio eradication and future prospects. Poliomyelitis is the viral disease that causes acute paralysis, muscle weakness, and autonomic dysfunction. It primarily affects children under age of 5. It mainly transmitted via fecal-oral route through the contaminated water. As of the year 2022, Pakistan remained one of the 2 countries where polio is still endemic, the other being Afghanistan. Numerous myths and misconceptions regarding the polio vaccine, lack of awareness and proper governance, and terrorism and difficult access to remote areas due to poor infrastructure are just some of the reasons why polio remain endemic in Pakistan to this day. Therefore, the government should take measures to ensure the safety and well-being of the healthcare workers as well as spread awareness regarding the importance of the polio vaccine while addressing the myths and misconceptions regarding said vaccines. Our second article is use of inactivated polio virus vaccine for polio virus outbreak response. With continued wild polio virus transmission in Afghanistan, Pakistan, and circulating vaccine-derived polio virus in certain countries, there exists an outgoing risk of importation of polio virus into other countries, including those that have been polio free for decades. Diversifying the polio virus outbreak response toolkit is essential to account for different public health and epidemiological contexts. In this personal view, they discuss the data on intestinal pharyngeal mucosa immunity induced by inactivated polio virus vaccine (IPV) and previous programmatic experience of the poliovirus outbreak response with IPV and outbreak response guidelines in the countries that exclusive use IPV. With recent report of the polio virus detection in the polio-free countries such as USA and the UK, it is important to assess the interplay of the virus transmission dynamics, vaccine impact on preventing paralysis and virus spread, and regulatory complexities of using oral poliovirus vaccine and IPV options for outbreak response. As the global eradication program navigate through the cessation of the routine OPV use with replacement by IPV, the stockpiling of the novel OPVs, clarity on the impact of the IP use will important for informed decision making by global, regional, and national policy makers. Now coming to the MCQ session. First MCQ is a 3-year-old child in the refugee camp develops fever followed by the asymmetric paralysis. Several other children in the camp also report flu-like symptoms. What is the most likely mode of transmission for this outbreak? Option A, blood transfusion. Option B, airborne droplets. Option C, fecal-oral. Option D, direct contact with saliva. Option E, vector-borne transmission.
C.
Yes, C is the right answer. MCQ number 2 is during environmental surveillance in Karachi, poliovirus is detected in the sewage samples. What does this indicates about the polio transmission in this region? Option A, there is the high likelihood of the symptomatic polio cases in the population. Option B, polio is no longer a public health threat in this area. Option C, asymptomatic carriers are contributing to the spread of the virus. Option D, surveillance system are not functioning effectively. Option E, there is no need for the vaccination campaign in this area. Answer is option C, asymptomatic carriers are contributing to the spread of the virus. A mother bring her infants for vaccination in an area with a high prevalence of the polio. She is unsure about the differences between the inactivated polio virus, IPV and oral polio virus. What is the main advantage of OPV in eradicating polio? Option A, it provides lifelong immunity after one dose. Option B, it is easier to administer and induce intestinal immunity. Option C, it has no risk of the vaccine associated paralytic poliomyelitis. Option D, it can be administered to individuals of all ages. Option E, it provides immunity to other viral infection.
B.
Yes, answer is option B. MCQ number 4 is a 5-year-old boy of KPK presented in the OPD with complaint of difficulty in speaking, breathing, swallowing, and doctors suspect the polio after history and examination. What type of the polio in this patient is having? Option A, asymptomatic polio. Option B, non-paralytic polio. Option C, spinal polio. Option D, bulbar polio. Option E, spinobulbar polio. 4 is option D, bulbar polio. In 1988, the World Health Assembly passed a resolution to eradicate polio to achieve the permanent reduction to zero, with no risk of reintroduction. In the same year, which one of the following program was launched by WHO? Option A, Global Polio Eradication Initiative. Option E, EPI. Option C, National Emergency Action Plan. Option D, Global Action Plan. Option E, Pulse Polio Immunization. Answer is option A, Global Polio Eradication Initiative. MCQ number 6 is a 30-year-old male who contracted polio in the childhood, present with the progressive muscle weakness and fatigue in his lower limbs. This condition is most likely due to option A, GBS Guillain-Barré syndrome, option B, post-polio syndrome, option C, chronic inflammatory demyelinating polyneuropathy, option D, A, A, amyotrophic lateral sclerosis, option E, peripheral neuropathy. Anyone? Answer is option B, post-polio syndrome. MCQ number 7 is a mother bring her 6-month-old infants to the clinic for vaccination. She asked about the difference between IPV and OPV. Which of the following is true about OPV? Option A, it require a booster dose every 6 months. Option B, it is associated with vaccine-derived poliovirus in rare cases. Option C, it is less effective than IPV in providing immunity. Option D, it is only been administered to child older than 2 years. Option E, it provide no protection against wild poliovirus. Answer is option B, it is associated with vaccine-derived poliovirus in rare cases. MCQ number 8 is a global health initiative aims to eradicate polio. Which of the following strategy is most critical for achieving this goal? Option A is exclusive reliance on routine immunization. Option B, targeted vaccination campaign in the endemic area. Option C, development of a new vaccine. Option D, treatment of the symptomatic cases. Option E, building a hospital infrastructure. Anyone? Answer is option B. MCQ number 9 is a healthcare worker in Karachi reports a 1-year-old child with fever followed by flaccid paralysis. Laboratory testing confirmed wild polio virus. It is the primary reason for persistent polio cases in Pakistan. Option A, poor immunization coverage in the urban area. Option B, lack of the healthcare infrastructure in the rural areas. Option C, vaccine refusal due to misconception and distrust. Option D, inadequate cold chain for vaccine storage. Option E, absence of the routine immunization program. Answer is option C, vaccine refusal due to misconception and distrust. During our vaccination campaign, our team encountered resistance from a community that believes polio vaccine causes sterility. What approach is most likely to overcome such challenge? Option A, threatening legal action against vaccine refusals. Option B, conducting a door-to-door vaccination program without community consent. Option C, encouraging religious and community leaders to advocate for the vaccination. Option D, introducing mandatory vaccination cards for the school admission. Option E, increasing financial incentives for vaccination teams. Anyone? Answer is option C. This is the key of MCQs. These are the references of my presentation. This is YouTube link where all presentations are uploaded. Kindly like and subscribe. And thank you.